But so another PowerPoint I've gone through. There's just a couple of small things I've left out that are just did not. There's a few things in this chapter they talk about, and you can't even see on ultrasound. So it's kind of like, what's the point of even putting it in the chapter? But we will finish kidneys today. I got to review. That's what I was just looking for at the beginning of class here. I got to review vascular here, and then Wednesday, Thursday, Friday. Well, two things. One, we might be going through 3 chapters in 3 days because the next 3 chapters are all relatively small. Certainly lower urinary tract. I hope to get through that in a day. The adrenal, it might be 2 days on adrenal. This is actually, yeah, maybe 2 days on adrenal. And then we also want to fit in a, we'll do a kidney test. We don't need to test on, oh, I'm sorry, I skipped goes to prostate is next. Okay, I think lower urinary tract on Wednesday, prostate gland, and then we go into adrenals. But like I said, I still think adrenal is going to be a 2-day thing. What else? Sorry, I didn't think about pulling up my schedule. Oh yeah, GI tract. Yeah, I think we have limited time. It's my fault for didn't realize how long we'd be out of classes. But we have limited time for testing on everything right now, so we'll test on kidneys. We'll talk about when that'll be. But in any case, if unless anyone has any complaints, or not necessarily complaints, but anything to talk about, speak now. All right, so I wanted to go over some of these things again, and then we're going to add on to this one. I go a little more casual, I think, this time. I'm feeling a little better. My back still hurts, but I'm a little better anyway. I started out on the angiomyolipomas simply because we see these a lot. We don't see them this large very often, nor do I see them breaking through from the cortex into the exterior. I don't see that very often. And something more like this is a little more common, even though that image is pretty horrible. Someone doesn't know how to use TGCs, right? And then we get to renal cell carcinomas. These guys are, this is the big one. This is the one you're always, when it comes to masses, this is the one you're always looking for. And it has a lot of different appearances. You cannot say they're echogenic. They're complex. They're, in this one page, we have a, this looks like an adenoma to me, homogeneous, isoechoic. And you have this one that's hyperechoic. And come to think about it, the rest of the kidney is a little hard to recognize. You kind of see the inferior tip of the kidney here. I think they're measuring an echogenic portion inside of a large, I never really looked at this picture that closely. This whole thing looks like a tumor to me. You know, my eyes were drawn to this just like yours were, I'm sure, but I think this is all tumor. So that's a, you know, two-tone tumor. This one, clearly, we have the lower pole of the kidney here looks, this part of the kidney all looks pretty good, but then we have a very heterogeneous kidney, solid cystic components. And then here again, almost a bilobed tumor on this person's left kidney. So most common malignant tumor, men, a little bit more than women. Multicystic diseases, not just a few cysts on the kidney. Don't freak out, because I'm sure we're going to find 1 or 2 cysts on you guys. But multicystic diseases have a greater incidence. So that includes polycystic kidneys, acquired cysts, tuberous sclerosis. All of them have a higher incidence of RCC. Could be a very large tumor when you finally find it, and metastasizes readily and may spread into the renal vein. So it says this is from your book, actually. I found it online as well, I think. No, I pulled it from another PowerPoint. And so showing the stages, stage 1 still within the kidney, hasn't spread at all. Stage 2 looks like it's broken through the outside of the kidney. Stage 3, it's starting to travel. Looks like this one started here and starting to travel down the vein. And then stage 4 is metastasis. So often, not always, but often highly vascular, containing numerous areas of hemorrhage, necrosis, or cystic degeneration. And like we said before, they could be hyperechoic. Is that directly from the book? This is not the first time that I've seen this as the same error. 50% appear hyperechoic, 40% appear more echogenic, which is another way of saying hyperechoic. So I need to let's just say 50%, 40%. Okay, I'll figure that one out. That's obviously an error. Trust me, like I said before, a lot less errors in this book than the other one. Oh God, 12% markedly hyperechoic. Okay, well that is, of course, markedly hyperechoic is echogenic, although it's more.
So basically, I've gathered here 102% of them are markedly or more echogenic or hypoechoic.
Yeah, that's a good point too. Yeah, so some of them can be echogenic to the point, and if they're small-ish, they could look like AMLs or, oh my God, angiomyolipomas. So, all right, yeah, I'll have to check the numbers on that. There was somewhere else in the book that I marked it down where they accidentally did the same thing, hyperechoic echogenic, and I'm wondering if the author has a little bit of a confusion there. Just some pictures here, nice, homogeneous, more hypoechoic than the rest of the kidney here. And I picked this one specifically because it has a couple of flecks of calcium. I think they're not shadowing, so we don't really know. But in a lot of tumors, calcium is a bad sign. So if you're wondering if it's benign or cancerous, if you find flecks of calcium, it has a higher percentage or a higher chance of being cancerous. And this as well as renal cell carcinoma. And then here we have a vascular renal cell carcinoma there as well. Oh yes, 20 and 30% of cases, calcification is identifiable and may appear punctuate, this is a punctuate calcification, these little dots in here. Amorphous or mottled. And I don't know the difference between amorphous and mottled. I mean, I know what the words mean, but they're pretty close. I don't think I have any words on this one. I just grab this CT. This guy's tumor is so big that it's actually just barely, you can see it's actually pushing the outside of the body. So this person, you'd be able to visibly see this person's tumor just by looking at it. And I don't see the other kidney at all. And I don't know if this, I think this might, yeah, I think this is the same person. I think I picked this up from a site that had the same person. So that's a pretty good size. Here we have a mass over here, hard to really even understand what we're looking at. Actually, this is liver and an IVC. So normally we would think of this as being, if this is a renal tumor, well, your IVC is on your right side, and so you'd say, well, that must be the right kidney, but something about it tells me that that's actually the left kidney, and it's extending across the body over to the left side, and the tumor is traveling up the IVC. The blood flow is traveling up the IVC, so that's kind of like it likes to go with the flow, with the blood flow. The reason I say this is I believe this is from the left kidney is because this is not technically right liver. This is left liver in the epigastrium, where it looks like we're dead center on the body. And this is stomach up here. At least I believe it to be stomach. A little bit, just a tiny little bit of gas in there. And then I recall that this is the same person. Well, I can't remember if this is the same person or not. If it is the same person, then I'm 100% incorrect, and that is a right-sided tumor because this left kidney is normal here. I can't remember if that's the same person or not. It's a decent sized mass. It's a decent sized mass. Yeah, well, not in any case. Oh, extension of the renal cell carcinoma into the renal vein occurs in 20 to 30% of patients, and thrombosis extends beyond that as well. The other tumor that we haven't really spoken about yet because it's a pediatric tumor is Wilms tumor, and that too has a tendency to travel up through the renal vein into the IVC. We talked about this the other day. I added this picture, though. I think I might have. Yeah, I thought I did. Transitional cell carcinomas. These are a little more hard to find. When you do find a tumor that is specifically in the pelvis, or perhaps in the ureter on the way out of the pelvis, then it's probably or has a higher chance of being TCC. Scanning pitfall they mention is mistaking prominent renal papilla as filling defects in the calyces in a setting of hydronephrosis. Okay, well, that's a little confusing. So this person here has a little bit of hydroureter. As I'm traveling along here, that's the ureter here, and the hydronephrosis comes up. It's very minor in the kidney, although it fills the lower pole a little bit more. And it looks like, and I certainly would be looking very carefully at this, that there could be tumors inside of the pelvis here. So obviously either a tumor or fungus balls, just like sludge can create sludge balls, fungus can actually do the same thing. But according to where I picked this up from, this is actually just the renal papilla, just having an odd look because it's surrounded by fluid. This certainly looks like a papilla. The larger one, it's a big papilla. I don't know. But in any case, supposedly not tumors there, although they look like tumors. This squamous cell, I already told you that this is actually not squamous cell because I could not find a single squamous cell ultrasound image on the internet, nor is there one in the book, which tells me that no one ever sees them. Lymphomas, we mentioned already, overall enlarged kidney, local lymph node involvement, kind of by definition. So if you see lymph nodes in the area and a kind of a bulky kidney, hypoechoic kidney, then that could be a lymphoma. Okay, now hydronephrosis, I added this from your book. And it kind of shows a progression of how, so this one has a dilated intrarenal pelvis. So this is more or less on the inside, it's a little bit dilated. That could be a normal variant, or it could be just a little bit of fluid buildup. Calyces, oftentimes called caliectasis. I have to write that down somewhere. But it makes sense, caliectasis. I said that word for years without really even breaking it down in my mind. Calyx, the calyces, are these little, I almost dropped an F-bomb for no reason at all. These little guys here are the calyces. Caliectasis, as in ectasia, as in, is just a widening. So caliectasis is what we sometimes call very minor hydronephrosis, can be called caliectasis sometimes. It develops even more. We have a blown out, a little bit of an extrarenal pelvis here, and the structure of the calyces is getting more or less destroyed. And I would say kind of more or less like this one is getting a little bit destroyed here. The normal architecture of the calyces is getting blown out. There's another form where it's going to look more like this. These look like individual cysts, definitely look like individual cysts, but when we rock back and forth, we'll see that these each connect somewhere. Like this one connects here. This one looks like it has a connection there. And these others will also have connections. And then, what is it? Dumbledore? I don't know. Sometimes we call this the bear claw or the bear paw. It looks like a big old bear. And at this point, we're getting probably some good kidney damage. So pregnancy, polyuria. Oh, one thing I wanted to say about polyuria is a lot of times people, especially with their pets, like their cats get renal failure a lot. And, you're looking at your dog, you're looking at your cat, or your grandmother, I don't know, we all have kidneys, and they're peeing all the time. So you think, oh, the kidneys are working fine, and you're peeing all the time. Well, remember I said that if your kidney wanted to kill you, it could. Because by action of blood going through the glomerulus, an enormous amount of fluid is removed from the bloodstream, and then it's drawn back in. Well, when you have polyuria, it could be that you actually have kidney failure, and that you're not drawing back nearly as much as you should be drawing back. So polyuria can be a really bad sign. Not necessarily, but it can be. Tumors can get in the way and cause hydronephrosis by blocking urine. Stones can block urine. Obstructions are UPJ, like this. These first, I'm not sure about this one. I can't see what's going on right there, but this, without being there and holding the transducer myself, I don't know for sure, but this looks like a UPJ, don't know, because I don't see the ureter at all in this one. In other words, there's an obstruction right here, either a stone, a stricture, a kink, something's going on within a centimeter of leaving the kidney. So that's a ureteral pelvic junction. And then UVJ is at the other end at the bladder, and that happens a lot too. So I went ahead and threw this one in here. Let's not talk about, well, grades. Grade 1, mild. Grade 2, moderate. Grade 3, marked. You can read the rest of that on your own, but for now, that's all I'm going to say. But intrinsic causes, calculi, hematoma, yes, neoplasms, something getting in the way, stricture or obstructions, ureteral seal, so that's at the, that would kind of be considered a UVJ obstruction, yeah, obstruction, because it's at that end of the ureter. Sloughed papilla, well, we'll talk about that today. Pyelonephrosis, so pus getting in there. Aberrant vessels, vesicular reflux. So reflux is when the urine comes from the bladder back up. Posterior urethral valves, that is something boys get, and specifically baby boys. I've never heard of anyone beyond a baby having it. I think rarely it does happen. I think we'll talk about that next semester though. Ectopic ureteral seal, ectopic ureteral seal, collecting system duplication. All right. Don't worry about the difference between ectopic ureteral seal and ureteral seal. It's, we've already talked about that. And so extrinsic, neoplasm, trauma, neurogenic bladder. That is a bladder that I used to see these all the time. Actually, I was a student at a teaching hospital, and what we had was there was a doctor or two there that had a really big wasn't a urinary or a nephrologist. It was it'll come to me in about 30 seconds when it doesn't matter anymore. Big practice where we would see patients all the time that didn't have conscious or unconscious control of their bladder, and because there was no the base of the nerves to the bladder were damaged, and so we saw a lot of that. Surgery, ligation, transections, edemas. Bladder outlet obstruction, in other words, urethra obstruction. That could be on a male, it could be in a large prostate. Neoplasm, prostatic hypertrophy, urethral problems, retroperitoneal fibrosis. We'll talk about that in the retroperitoneal part. Gynecological, tubal-ovarian abscess, endometriosis, pregnancy, inflammatory lesions, gastrointestinal, and retroperitoneum. So there's a lot of things going on here. By far, the more common would just be stones and strictures. And a lot of these cause, like the tubal-ovarian abscesses, the retroperitoneal fibrosis, they cause strictures. So it's all in the same family. Okay, I think we did this one okay. So nephroliths, typical small stone and a really good catch by this person to see this shadow, because quite frankly, that is almost invisible, that shadow, and especially along this dirty shadowing, which, like I said, I don't really even understand why kidneys do this. They just simply do sometimes. And you look at this kidney, it doesn't really have it. This kidney has, by the way, a lot of edge shadowing, because there's a lot of rounded structures inside of the kidney. And so it causes this shadowing, and that really catches your eye. If you're a good sonographer, you see that, you're like, oh, there's a stone. I'm like, oh, wait, no, there isn't. Oh, no, there isn't. Oh, yeah, there is. There's a stone on this one. So this one actually is a stone. This one's edge shadowing off of the kidney. Yeah, edge shadowing off of the kidney itself. It's actually kind of interesting, this one. It comes down and then it actually bends. So there's a little change in direction of this going, and it goes right through another tissue face right there. And then these two are both a twinkle artifact. Remember, we're going to learn how to use this, although if we don't have any stones, it's hard to reproduce without a stone. But one thing your book does say is that you want your color right priority up. And so we didn't talk about that a lot in physics. We did a little bit. Sometimes the machine just calls that sensitivity, color sensitivity, but your color right priority is really your sensitivity, and so you're dialing that up in order to get this to happen. Twinkle artifact, and those really help out. Actually, I had a radiologist who had never heard of that, and it happens. I mean, some people just never been taught certain things, and if you weren't taught it, you're not going to know it. This doctor, I had a patient with just like on the bottom of the bladder, the dependent portion. So when I rolled the patient, they still had it on the bottom. All these little, lots of thousands of little echoes down here, and they shadowed a bit, but not a lot. I mean, in group, like in the mass of it's shadowed, but not a ton. And it was kind of hard to see what was going on. And I put color on, and I got twinkle artifact all throughout, like the entire bottom of the bladder shone with twinkle artifact. And I went to him and told him about it. He says, "What are you talking about?" I said, "He has sand." He has bladder sand. And so he wasn't so sure. He never heard of that, but they scoped him, and sure enough, bladder sand. So thousands of little nephroliths had gone from the kidney into the bladder. They're all so small, it probably didn't hurt them too bad. Anyway. Let's see. I think I added this. 80% of nephrolithiases contain some form of calcium. So most of them will shadow. Uric acid, cysteine, and struvite. These are less likely to shadow. If you need shadowing, vary your gain settings, get your focal point right there, and turn off spatial compounding. Remember, spatial compounding brings in sound from slightly different directions. And if you have a very, very faint shadow, like this shadow up top, you have compounding here, you're not going to see that shadow. It's going to go away. Let me tell you something. Without the shadow, well, I guess that's a pretty decent size. You should be able to see that. But if that were sitting inside of a more echogenic pelvis, you could actually miss that. So it's good to just kind of turn it off, turn it back on when you don't need it. A little more twinkle artifact down there. Staghorn, and I put it in one slide just for the heck of it, emphysematous pyelonephritis, because they kind of, in a way, have a similar appearance, except emphysematous, just like regular air or air anywhere else, usually has dirty shadowing. With echogenics, where the sound first hits the air, it's quite echogenic, and then it's dirty after it. Whereas the staghorn, bright line and then a darker shadow because of the makeup of the staghorn. You would think these would be easy to see, and if you're not expecting them, if you're expecting them, you can't help but notice them. But if you're not expecting it, you think, "Ah, dang, bowel's in the way. I can't get this bowel out of the way of the kidney." Well, no, it's not bowel in the kidney or over the kidney. It's air in the kidney. Nephrocalcinosis. Now, we mentioned medullary sponge kidney. Medullary sponge is when the medullary pyramids themselves, they have cystic dilation of the collecting tubules. And all of those extra interfaces, and it's a little bit of I think it took physicists, ultrasound physicists, a while to figure it out. but it's all those little extra interfaces causes it to be echogenic, even though they're filled with fluid. So it's very unusual. Same thing happens with the juvenile form of polycystic kidney disease. The cysts are absolutely tiny. Those kidneys can look extremely large and echogenic. So even though you're looking at 1,000 cysts, you don't see the fluid in the cysts. But in any case, so a nephrocalcinosis can occur from medullary sponge kidney, but that's not the only way. So they are related, but they're not the same thing. Like this one could have started out as simple medullary sponge kidney. Urine gets stuck in all of those cystic spaces. Calcium forms inside of those cystic spaces, and they become calcified, and you get medullary nephrocalcinosis. Same thing down here. But we also have cortical nephrocalcinosis, and that is happening up in the cortex with the glomeruli. So glomerulonephritis can cause calcifications around there. Acute cortical necrosis. A lot of times when tissue dies or bleeds, calcification is left behind. Vitamin D intoxication, hyperparathyroidism controls your calcium balance, so that makes sense. And AIDS just sucks. Oh, and I think I added this. Obviously, we cannot use the right kidney to evaluate the liver echogenicity. So normally the kidney is pretty standard on its echogenicity, but when this occurs, when you get something that like this, oh God, I just realized you guys might not even. If you're not seeing my arrow, you should have said something. But if this whole time you haven't been able to see my arrow, I really apologize. But hopefully you've been able to figure it out. Okay. So, anyways, yeah, the cortical nephrocalcinosis, you cannot use that to determine liver echogenicity for obvious reasons. AV fistulas, probably after trauma, probably after a biopsy. Remember, that is when a needle goes through an artery and a vein, and now you have a arterial venous connection where there shouldn't be. Pseudoaneurysms, same thing, but rather than being an artery to a venous, it's simply an artery, and the blood is swirling around, captured, not just going everywhere, but captured right here. So this is obviously going counterclockwise because it's going up and then down and then like that. Hematomas, varied appearance. So we have subcapsular hematoma here, subcapsular hematoma there. Little hematoma. This was an infarct. So the blood supply got blocked and this part of the kidney died. And that's resolving blood when it's echogenic like that. UTIs, incidence of infection greatest in women from 15 to 24 years of age, for fairly obvious reasons, but I'll mention it anyway because I didn't last time, I think. Female urethra is, what, 1.5 centimeters? I don't want to say what mine is. No, but obviously the male urethra is much longer. And so the chances of bacteria going up the female urethra is much higher than in males. Yeah. So let's see, on this, just looking at this, I did write something up here. Filled sinus and loss of cortical medullary differentiation. Cortical medullary, so that means where does the cortex end and the medulla begin? You can't see it here. You can't see it over here. There's no pyramids. Actually, there might be a rib shadow right here, so I'm not even sure you can see it here in the middle. So there's an overall fuzziness to this kidney. And also, can't really see an echogenic cortex. Now, it could be because this is a child, a young child who does not have any fat, or, and I don't think this is, I think this is an older, an adult. This is actually filled with pyrulent material, or in other words, kind of pus is in the collecting system here. Acute pyelonephritis, so pus, it's a nephritis with pus. 85% of cases, E. coli, so that is gut bacteria. Acute suppurative bacterial inflammation. So once again, suppurative is another way of saying pus forming. Dysuria, painful urine frequency and urgency can all occur. Oh, and this kidney was interesting. Just look at there's an outer section, almost like a subcapsular hematoma, and you can see it over here as well. There's a tone difference. There's an echogenicity difference between here and here, and I don't honestly have a great explanation for that, but I think, yeah. This kidney's not, other than that up here, not too bad looking. The pelvis looks pretty normal. Some, some fat here, and then some dirty shadowing here. So this could be something going on there. This kidney in transverse is completely, it's just a ball. I mean, normally we see a nice C-shaped organ here, and this is a real mess. So definitely something going on when you look at this in transverse. Oh yeah, and this is the same patient. You don't get a perspective on size here, but over here you do. Huge kidney compared to the left. Huge kidney. So. Emphysematous pyelonephritis, so we have air all the way up, not just in the collecting system, but yeah, all the way up to the cortex. We have, so mortality rate is high, is 30 to 40%, tends to be older diabetic patients, immunosuppressed patients, and women with urinary tract obstructions. Chronic atrophic pyelonephritis. So atrophic, atrophy. Look at this. I've seen plenty of kidneys that look like this. Look at this. That is, like, from here to here is the entire thickness, not just of the cortex, of the parenchyma. So basically this whole part of the kidney is non-functional. Then this person has a little bit of functional kidney here. At least we hope they do. On this person, it wasn't until they got all, that's not a good picture, but it wasn't until we all got all the way down here, and then suddenly dramatic thinning of the the cortex, but the total parenchyma, totally thinned out there. So this occurs with recurrent renal inflammatory bouts, eventually scar the kidney, and obstructions contribute to parenchymal atrophy. So it's chronic atrophic pyelonephritis. And then we have this one in here just because they wanted to put X at the beginning of the word. Xanthogranulomatosis. pyelonephritis, xanthogranulomatosis pyelonephritis. Easier to say, XPG. A rare form of chronic infection. So this is the same thing as chronic pyelonephritis up here, except for instead of becoming atrophic, normal renal parenchyma is replaced with lipid-laden, foamy macrophages. By the way, that's kind of weird. That's the same thing that causes plaque in your, shorter here. That's the same thing that causes plaque in your carotid artery, for instance. Lipid-laden, foamy is because that's the way they look, macrophages. Plasma cells and multi-nucleated giant cells, all part of the. So it's kind of looks like almost like an immune response. And oh, that's the other thing. Staghorn calculus is present like 90% of the time. And so this person does have a staghorn here. And so all of this is just macrophages, just filled up macrophages. And then abscesses. Acute or chronic abscesses are septic conditions that produce unilateral flank pain, chills, fever, and point tenderness. Anything that is septic is very dangerous. Well, let's see, this kidney here looks somewhat normal at this end, and then the whole end here and outside the kidney is a mess, a very heterogeneous view. One thing your book mentions is that when this starts to go outside and fills the renal fascia, the kidney does not move with respirations. Here we have a really bulky, ugly, hard to even recognize as a kidney. And then they're pointing out this area, but really, I would say the entire kidney here is filled with abscess. Well, maybe that's the abscess and the rest is filled with more infection, but maybe less heterogeneous abscess. Pyonephrosis. We'll just do a few more guys right now. Presence of pyrulent material in the renal collecting system. So we have hydronephrosis with pus. So this is all pus material. Up in here, that's something a little bit different. That looks like a dead papilla. Remember, the papilla is that's the tip of the pyramid, and that's what that looks like to me. But in any case, a variable owing to age, presence of tissue and cellular debris produce low-level echoes. If pyelonephrosis is chronic, diffuse xanthogranulomatosis pyelonephritis may result. So we go from pus in here to fungal infections, and was that those damn white Canadians again? Most common cause, Candida. My wife laughs at me. I can't say it. It's just so simple, but I can't say it. Candida albicans. Sonography appearance of fungal infections may be similar or identical to that APN. That's acute papillary necrosis. That actually was what I was just mentioning. This looks like acute papillary necrosis right there. But these don't look like papillary necrosis to me. These look like fungal balls, appear as hyperechoic, non-shadowing masses. So these are both fungal balls. This is these are both children, young children, babies, in fact, I think. But yeah, fungal balls there. Okay, let's take a break. Could we have a few that I just kind of zip through, and because there's not much to talk about with them. So let's go ahead and take a break. It's 1:47. It's gonna, I think it's gonna be a short day. So let's go and come back at right at 2 o'clock. I'll see you guys at 2. Okay. So one of the difficulties of talking about this, whether we're in class or online, is a lot of these things are really hard to decipher from. And I don't care if you're a new tech or if you've been doing this for a long time. And so I thought, between pyelonephritis and fungal diseases, and they all, honestly, they kind of look the same. The only thing you're going to know is that the doctor or the script is going to say something, or the medical record is going to say something to the effect that might give you an idea of what you're probably more likely to be looking for. So this person here, I was just looking up some images, and it's kind of just a nice little case study. Once again, I like to add syllables where they don't belong. Pyelonephritis, dysuria, painful urine, referred with laboratory findings of a UTI. So let's look at this kidney here. Initially, this picture's pretty good. We don't see clearly, certainly not over here, we don't clearly see a cortical medullary differentiate. That's another word I got to throw up there. Nah, you guys have already seen that. We don't see it clearly, but sometimes you gotta know the difference between overall quality of the image or truly a loss of the cortical medullary junction differentiation. This is a fuzzy picture. I do not see pyramids. I have no idea how to measure the cortex for this person. Over here, it's a little funny looking. But let's see some other pictures. Now, look at that picture. Yeah, well, we're not really seeing, maybe part of a pyramid here, but I don't know. Not really seeing it. Why can't I go in this straight line here? Okay. Now, I got to wonder what they did differently with their scanning technique, because this does not look like the same person, and it supposedly is. Now, this is truly a fuzzy, idiot, Kurt. How do I not notice that? Curved, linear, curved, linear. So huge difference. In the linear, and not only we're actually starting to see a differentiation between the cortex and the medulla, the medullary pyramids, but the pyramids are the wrong color. Interesting. They should be more hypocoloric than the cortex. So that is an interesting finding there. Yeah, kind of just an overall, a little bit fuzzy, a little bit bulky appearance here. Yep, can't really see that. Oh, I believe this arrow here is pointing to what appears to be, you can see a thickness right here. It's kind of a thickness of the that epithelial lining of the collecting system. So that is an indication of a nephritis type, or some kind of itis causing thickening there. Oh yeah, it says right here, urothelial thickening. Did the other ones have? No, okay. And on this one, they have a little balloon puppy created by some clown. So this little echogenic, I don't know, is that a pyramid? It's hard to say because it goes all the way up to the renal fascia. So I don't know if I can call that echogenic pyramid. I'd say the pyramids are mostly not seen. Well, let's see, what does it say? Right kidney shows ill-defined hyperechoic parenchymal areas without vascularity. So yeah, there's no vascularity in that. And upper pole and interpolar regions, there's no solid or cystic area in the renal parenchyma. So there's no solid or cystic. There's no cysts. There's no neoplasms. There's no lesions. Renal artery and vein are patent. There is no calculus or back pressure change. That terminology, I can only assume, means that they did a pulse wave on there, and the arterial flow seems normal. There is urothelial thickening involving the renal pelvic calyceal system. So thickening of when they got in there close, they were able to see some thickening of the kind of like the walls of the sinus there, or the collecting system. Left kidney bladders were normal. And were there any other pictures up here? No, that was it. Okay, then 10-day follow-up. And now, oh, well, it's just, uh-oh, it's thinking. Bladder. Bladder looks pretty normal. That is, I mean, this is just reverb artifact up here. Oh, it says calculus or back pressure change. I wonder if that's their terminology for hydro. I don't know if they just call it hydro though. Okay, so obviously they got an arrow pointing to this, but that's not looking good, and there doesn't seem to be a whole lot of blood flow over here. There's more of that thickening of the collecting system. And then you got this area here. It looks a little scary. They go from curved LS7 to, no, it's a linear. Why does it seem slightly curved? To a linear 9. So higher frequency here, and they're able to get this a little bit better. But that's, that wasn't there. It's not a cyst. Cysts don't grow in 10-day follow-ups. So that's definitely something new here. And yeah, look at this little echogenic area. This does not have blood flow in it. Oh, LS. Oh, that is a curve. Why is it called an L? L usually stands for linear. Yeah, definitely see some complexity here now. So a 9-centimeter kidney and a 2.3 centimeter lesion there. And you could still see that thickening of the collecting system. Walls are a little thick here. Wait, I'm going all over the place. All right, I think I've gone through all of them. Right kidney shows ill-defined hyperechoic parenchymal areas without vascularity. In upper pole, there's an avascular anechoic area in lower pole renal parenchyma. Renal artery and vein are patent. There is no calculus or back pressure change. So I'm not 100% sure what back pressure change means. I thought it was arterial, but maybe they mean back pressure as in blocking urine. There is urothelial thickening involving the renal pelvic calyceal system. Initial ultrasound shows right pyelonephritis. 10-day follow-up ultrasound shows a complication, renal abscess. So that's interesting. Okay, this is Radiopedia. They tend to be they don't get into a whole lot of history. They just kind of say what it is and keep moving. But it's a good website to go to. All right. So I mentioned I grabbed another fungal ball picture. Oh, and here's what well, that's interesting. Ascites. Doesn't have to be lot to be ascites. It could be a tiny little piece like that. So, shit. No. Sorry. Oh, good. We are recording. All right. Yeah. So, tiny little bit of ascites tells you something's going on. Whether it has to do with his kidney or not, I don't know. It could be something completely different. Echogenicity of this kidney is actually greater than the liver. That is rare. This liver looks normal. So I'm going to say the kidney, beyond the fungal balls, I'm going to say the kidney is abnormal. Usually it's the liver, but sometimes it is the kidney. That's the troublemaker. We have this is gas right here from probably the transverse or ascending colon. That's a decent sized pocket of gas there. And so, we're not seeing the lower pole of this kidney, and that's a constant problem. But this is what I'm talking about, how, if you can imagine where this appearance is over here, you think, oh, that's stupid intestines in the way. I can't see the kidney well. And no, actually you're seeing the kidney. It's just filled with air. So those things can be hard to see. Let's get this back down to a more reasonable size. Whoops. Seriously, guys. Okay. I could not find any decent images of schistole in the kidney, and in the bladder. Bladder was very uneventful, and kidney was non-existent. So just mention that schistosomiasis can occur. It's a disease caused by parasitic worms residing in fresh water in the form of larvae. Prevalent in developing countries, larvae penetrate human skin, causing a rash. Shed tails, enter lymphatic vessels and capillaries, then migrate to the portal system. So we've already talked about how you can see those in the liver, mesenteric veins, and urinary system as well. So kidneys may appear normal or demonstrate ureteral obstruction and hydronephrosis. Calcifications may be present within the bladder and bladder wall. So yeah, but I didn't get anything good on this. So just know if the person, this is not something you're going to be looking for. Unless you go to Africa to do ultrasounds or something, you're probably not going to be finding this. But if you are in Africa, or if you have someone who just came in from say a third world country, and they have evidence of schistosomiasis in the liver, understand that it can be in the kidneys and bladder as well. Tuberculosis, this can happen many, many years after initial infection. Tuberculosis is the body walls it off. In most people, it actually does a very good job of walling it off, and that's it. Some people, not so good. Renal tuberculosis, we think of this as a lung disease, but it can spread outside the lungs. Renal TB is acquired by hematogenous, that word. In other words, blood and spread through the blood system. is a mycobacterium associated with concurrent or previous pulmonary infections. Patients have an abnormal chest radiograph 30% of the time, and only 10% show signs of active pulmonary TB. So you get renal papillary necrosis. I have another slide on that. And renal pelvis uretropelvic junction fibrosis. So I don't know. Let's see. I grab these images. A up here demonstrates a small irregular caseous cavity in the upper part of the left renal parenchyma. So something's going on right here. If you don't know the person has TB, there's no way of possibly knowing it from ultrasound. So that's not the point. The point is just to find whatever it is. And B, image revealing a tuberous how do you tuberculosis cavity. I think I need to go to bed again. With fine septate within, in the lower part of the left kidney of another patient, note marked urothelial thickening in this dilated system. And that is something I was going to point out. This just looks thickened. And you normally don't even see the walls here, and you're kind of seeing the thickening all around. Definitely there's some thickening there. I don't know if you can see that. Definitely some thickening along here, some thickening there as well. So that's not a normal, aside from the fact that there's a little bit of hydronephrosis in here, this is not completely normal. And of course, we're also looking at this lesion here. Sonography image revealing irregular sonolucent cavities with semi-solid echo texture. This may be actually what they're talking about over here, papillary necrosis. Looks a little bit like papillary necrosis, but not a beautiful image of it. So let's see if we can find another one. So once again, you're not going to see this every day for sure, but if you know the patient already has TB and you start seeing things like this, you keep that in the back of your mind. Okay, medical renal disease. Disease of the nephron, vascular, and or interstitial tissue. So this medical renal disease covers a lot of bases there. It could be a drug overdose. It could be AIDS or other immunocompromised type patients. Hallmark of parenchymal renal disease is diffuse increase in echogenicity throughout the parenchyma of both kidneys. So this person has a renal length of 8.3 centimeters. That is atrophic. That is too small for an adult. It is also barely visible beyond the fact that it's slightly reniform in shape. I mean, it is reniform in shape, but it's very hard to see. It's becoming echogenic and matching the background fat and connective tissue. So once again, this is a normal looking liver, and you cannot measure, you cannot tell the liver's echogenicity comparing it to this kidney, because obviously the kidney's incorrect. AP on this kidney is 2.6 centimeters, and the overall parenchymal thickness is 0.4 centimeters, which is smaller than just the cortex alone should be, but that's the entire parenchyma. So this is a dead kidney. There's no way this kidney is really doing anything. This kidney is not dead, although it might be in trouble. I don't trust their measurement. I don't see that they have the lower pole fully imaged. So this could come out a little farther, probably, but I don't know. Definitely an echogenic parenchyma compared to this liver, which honestly, this liver doesn't look very good either. Yeah, that's a diseased liver as well. In fact, I think it's probably whatever is affecting this liver is affecting the kidney too. And up here, once again, another echogenic kidney. Looks like, I assume, fluid in the middle. It's hypoechoic, a little bit of fluid in the collecting system, a little bit of kaliectasis. Oh, what else? Yeah. So kind of under the medical renal disease in general, AIDS can cause a post-renal failure, maybe due to hydronephrosis or AIDS-related nephropathy and nephrotoxic drug use. So this is drug use that they have to be taking, not that they want to be taking. It's most common sonographic findings are increased echogenicity of the cortex, decreased definition of cortical medullary junction, and yeah, kind of hard to say where the cortex ends and the medulla begins. Kind of see a pyramid here a little bit. And decreased renal sinus fat. Well, yeah, there is no sinus on this person. Interesting. Diabetic nephropathy. Unfortunately, diabetics have a lot of issues. Nephropathy, kidney pathologic. So, leading cause of chronic kidney disease, chronic renal failure, and cause of diabetic morbidity and mortality. So, this picture, well, I believe is from your book. 46-year-old man has end-stage renal failure and a long history of diabetes. I have a longitudinal image here. A small hyperechoic kidney. Now here's a funny thing. I went to scan someone who used to work at Pima, and this was their kidney. I mean, this wasn't actually their kidney, but this is exactly what their kidney looked like. And I was shocked because that's generally not a good thing. So papillary necrosis affect the renal medulla and involves sloughed. So if something is sloughed, that means it's dead, or at least a layer of it is died and sloughed off, kind of a sloughed papilla, or calcifications. Well, remember what I said, calcifications and necrosis oftentimes go hand in hand, or calcifications and bleeding go hand in hand, because that's what's left behind as a little tiny calcifications from the renal medullary pyramid. So what happens is that this tissue right here is the sloughed off, the like a layer of skin, as it were, has been peeled from the papilla of the medulla. It ends up getting surrounded by a little bit of fluid. So you get these almost like these cysts with some kind of texture in the middle, or some kind of tissue in the middle of them. And it will be several of them, if not many of them, around the kidney. And that's happens with quite a few. Sometimes drug use, let's see, alcohol abuse. You know what, I didn't write it all down. Maybe I'll look that up real quick here. Here's just another image of these papilla with fluid around them. So it's kind of freaked me out when an old friend of mine had that. Kind of like, you know, what do you say? Not really. So I told him. But He did not have any drug issues. He did not have any kidney issues that he knew of anyway. I think getting delivery or something. All right, I'll look that up later. Acute kidney injury, you will see this on a script sometimes. Oftentimes acute kidney injury and then just looks normal. So inability of the kidneys to remove accumulated metabolites from the blood. In other words, they're not working. 10,000 persons annually in the United States, mortality rate 60%. That seems absolutely insane. Real-time sonography of native kidneys is most often normal in the setting of AKI, and that's been my experience actually, is a lot of normals. Once acute kidney injury has been established as a diagnosis, sonography's most important role is to provide accurate evaluation of hydronephrosis, so that we can easily see. So if there is a hydro, we'll find that. Distinguish post-renal or obstructive causes, and screen for any kind of other parenchymal diseases that we could actually see. So, like I said, oftentimes we see nothing, but what we're really looking for is tumors, hydro, or anything else going on. Ooh, I think we are. Okay. Chronic kidney disease. Irreversible condition characterized by diminished function of the nephrons, resulting in decreased glomerular filtration rate, renal flow, blood flow, tubular function, and resorptive capability. Remember, you could urinate like crazy and think, boy, my kidneys sure do work well. And that's the exact opposite. If you're urinating like crazy for no good reason, like, you know, you just seem to always urinate. And I'm not talking about frequency, that's the different issue. I'm talking about large volumes. That could be an indication of a kidney problem. Typically, these kidneys become echogenic, small, shrunken, definitive of end-stage renal disease. And then I think this is my last, pretty much my last slide. Dialysis. So my best friend from high school just started going on dialysis. And he says he doesn't. First thing I asked him is, well, you know, I said something about diabetes. He says, no, I don't have diabetes. I'm like, you're 375 pounds, and you've been 375 pounds for the last 20 years, you have diabetes. But he says he doesn't. I don't know. Dialysis, blood from artery moves through artificial kidney unit designed to assume the physiologic function of nephrons, after which the blood is returned to a vein. We actually talk about this next semester a bit, because one of the things that we were looking at in the arm, usually the arm, is the patency of a arterial venous fistula, a fistula purposely created to quickly move blood through the machine and back into the body. Sonography is a useful monitoring the kidneys of patients who are receiving long-term hemodialysis. Complications are acquired cysts and tumors. Remember, cystic disease, even the acquired cysts of dialysis patients, gives a higher incidence of renal cell carcinoma. So that's that. And I decided, because in the book, I didn't see it in the book anywhere, caliectasis, mild hydronephrosis displaying only calyces. So this is a real mild hydro. This is not really causing the person any problems, know of anyway. But you can clearly see it's just going up to the calyces, but really barely displaying anything as far as collecting system goes. And otherwise, actually a good example of But this is what makes, like when I was in school, they made a big, my teacher made a big deal about cortical medullary differentiation. And it is a big deal. But it's kind of like simple cysts that never look simple because you always have so much interference, so much speckle and reverb artifact, and all the things that make a simple cyst not so simple on your screen are the same worries that I have. Does this person have a loss of cortical medullary differentiation because I cannot see pyramids? Or is the quality of the image so poor that I can't see that differentiation? So that's a tough one. This looks like, otherwise, looks like a healthy kidney. I don't know. Now, and I'll just say, my wife, oh, you know what? I did mention, she asked me if I talked about her disease. It's really not much of a disease, but I told her no. But you know what I did? I talked about, it's called thin basement membrane is the common term for it. And that's just the fenestrae between, in her glomerulus, the holes are a little bit too large. And so blood, red blood cells and larger proteins are pushed out and they're not sucked, they're not filtered back in. So she always has a little bit of hematuria and proteinuria. But that's, like I said, a pretty mild disease. Anyhow, 2:30, not too bad. Kidney exam. Let's do that every time. Where are all my little, sorry, usually everything on Zoom is out front and I can't get them out of the way, and now for some reason right now they're all behind, so I can't see anything. I can't even see if you're all there. There you are. Okay, cool. All right. So kidney exam, open, once again, open book. I don't know yet, 20, 30 questions. I'll give you a minute and a half per question. I'll give you 2 minutes per question, only because this is such a big chapter. I could see taking longer to find the questions you're looking for. So I will give you 2 minutes per question. We could do it Wednesday after class, or Thursday after class. I don't want to wait till Friday because then we're like a chapter and a half, maybe 2 chapters behind. You guys have any opinions on that?
I'm good with Wednesday. Kidneys, right?
Yeah, Wednesday's good.
Wednesday's good. Yeah, Wednesday. Kidneys, right?
I think Wednesday. I think, you know, if it's open book, I think that's pretty good. Okay, I'll have that exam ready by Wednesday. 2 minutes per exam, since it's such a big chapter. I think it's actually bigger than the liver chapter. The good news is, oh God, musculus, that's a huge chapter. Pretty much every other chapter is 1 to 2 days rather than 1 to 2 weeks. So, which is good and bad. We zoom through a chapter and your head will spin, but at least you won't be as bored. I think, and I don't know what you guys' opinions are. I think the PowerPoints are helpful as far as images go. Perhaps keeps me a little more in line with the book, but I know I have a hard time with them. I think they're boring, but if you guys have a different opinion, you like the PowerPoints, let me know, and I'll just continue doing more PowerPoints or combination of PowerPoint and Sketchbook. So, and sometimes it's just going to be decided by how the chapter works out. But anyway, any questions, comments, or anything?
Mr. S?
Yep.
And is it just for chapter 10?
Yes.
Okay.
Yeah.
And how many questions?
I can tell you let's see, course tools. No, that's not it. Approximately 25. There's 25 from the publisher. So, and maybe I'll add one of my infamous pictures and create a bunch of anatomy questions from that. All right. So yeah, it looks like I noticed today that I forgot to put the Fridays. Well, Friday's lecture wasn't that good anyway, but I have to put that up on YouTube, and then today's up on YouTube. And then list it in Blackboard, put out an announcement. And the announcements are more of a placeholder for other people to look at more than you guys. But so, all right. Nothing else? Oh God.